Hello class, this is Emergency Care and Transportation of the Sick and Injured, Chapter 35, Geriatric Emergencies. And in this chapter, we'll be dealing with older people and specifically the complications that can come with dealing with people who are older and most of the time have one or more chronic conditions as well as susceptibility to falls, etc. So that's what we'll be doing in this chapter specifically. So geriatrics is defined in the realm of rescue medicine and medicine in general as the assessment and treatment of a disease in a person who is aged 65 years or older. The baby boomer generation, and these are people born between 1946 and 1964, are more active and fit than people their age were in previous generations. 65 years is used as the threshold age to be consistent with the definition used by other medical groups and governmental agencies. How fast one specifically ages is a function of genetics, lifestyle, and sometimes attitude. The older population is growing to a larger percentage of the overall population. Geriatric patients present as a special challenge for healthcare providers because the classic presentation of injuries and illness are often altered by the presence of chronic conditions, multiple medications, and the sheer physiology of aging. As older population increases, communities, companies, and hospitals are encouraging awareness of geriatric issues, mainly because they're just more common. There are more older people. So some general considerations to keep in mind. It is important to understand and appreciate how the life of an older person might differ from yours or a younger person. Older people may have recently lost a spouse, may face financial difficulties, or be struggling to stay independent. It takes time and patience to interact with an older person. Have patience and always treat that person with respect. Make sure to attempt every opportunity to avoid ageism, which is the stereotyping of older people that often leads to discrimination. Not all older people have dementia. Not all older people are hard of hearing. Not all older people are sedentary or immobile. And older people can stay fit and be active even though they are not able to perform at the same level as they did in their youth. Let's talk about communication with older adults. Effective verbal communication skills are essential to the successful assessment and treatment of older patients, as it is with all patients. But there are some special considerations. The aging process begins with changes in vision, hearing, taste, smell, touch, and pain sensation. Changes in communication abilities accompany aging, sometimes such as dementia or other diseases. As far as communication techniques, you need to bear in mind that your first words to the patient and the attitude behind them can gain or lose a patient's trust. Speak respectfully when you introduce yourself. Address the patient by using sir or ma'am. If you know the patient's last name, use Mr. or Mrs. and never or Miss. Sometimes older people aren't married and never have been. Use it if you know it, and never use familiar or casual terms when referring to your patients unless they have invited you to do so. When you interview an older patient, the following techniques should be used. Identify yourself and be aware of how you present yourself. Look directly at the patient at eye level and ensure good lighting. Speak slowly and distinctly. Have one person talk to the patient and ask only one question at a time. Do not assume, however, that all older patients are hard of hearing. In fact, that they find that very insulting. Give the patient time to respond unless the condition appears to be urgent. and listen to the answer the patient gives you. Explain what you will do before you do it. Do not talk about the patient in front of him or her as though the patient is not there. Some common complaints and leading causes of death in older people are the following. First, there's the changing physiology of geriatric patients, and it can predispose that entire population to a host of problems that are not seen in younger people. A simple rib fracture in an 80 or 90-year-old can result in pneumonia or even death. And a hip fracture from a low mechanism fall is common in older people and may have dire consequences. Hip fractures are more likely to occur when bones are weakened by osteoporosis or infection. Sedentary behavior while healing can predispose the patient to pneumonia and blood clots. This is Table 35-1, and it is a list of common conditions and leading causes of deaths in geriatric patients. And you need to be familiar with it so you know to look for it. There are changes in the body as people age. Human growth and development peaks in the late 20s and early 30s, at which point the aging process begins. The process of aging is gradual and starts much earlier than most people realize. The aging process can vary dramatically from one person to another, and the aging process is inevitably accompanied by changes in physiologic function, such as a decline in the function of liver and kidneys, and all tissues in the body undergo aging. The decrease in functional capacity of various organ systems is normal, but it can also affect the way in which a patient responds to illness. Do not mistake the changes in physiology for signs of illness and give treatment when none is necessary. At the other end of the spectrum, however, do not attribute genuine disease symptoms to quote-unquote just getting old and therefore neglect their treatment. Changes in the respiratory system are common, and you have not only changes in the respiratory system, but the anatomy and physiology is such that age-related changes can predispose an older adult to respiratory illness. One of the conditions contributing to breathing problems is weakening of the airway musculature, which can cause decreased breathing capacity. In other words, they just have, in general, not in every case, but lower tidal volume. And that lower tidal volume is brought about because older patients have less help from the muscles in the chest wall, and when they have trouble breathing, things are exacerbated. Also, the alveoli in the lung tissue can become enlarged, and the elasticity of the alveoli decreases, making it harder for older patients to expel used air. The body's chemoreceptors, which monitor the change in oxygen and carbon dioxide levels in the blood, slow with age, causing the body to respond more slowly to hypoxia. Let's talk about the pathophysiology that's the result of that. First, we'll talk about pneumonia specifically. Chronic lower respiratory disease, influenza, and pneumonia are in the top 5 causes of geriatric death. Pneumonia is an inflammation and/or infection of the lung from bacterial, viral, or fungal causes, and it is the leading cause of death from infection in Americans older than 65 years. Aging causes some immune suppression and increases the risk of contracting infections like pneumonia. You also have increased mucus production in the respiratory system, along with pulmonary secretions and the inflammatory effects of infection that all interfere with the ability of the alveoli to oxygenate blood. Management of pneumonia is the same for any patient. However, maintain a high index of suspicion for any geriatric patient with signs and symptoms of pneumonia. Remember to wear respiratory protection when assessing a patient with a potentially infectious respiratory disease. Now let's talk about pulmonary embolism. Pulmonary embolism is a condition that causes a sudden blockage of an artery by a venous clot. A patient with a pulmonary embolism will present with shortness of breath and sometimes chest pain, and it can be confused with a cardiac, lung, or a musculoskeletal problem. Risk factors for pulmonary embolism include living in a nursing home or recent hospitalization for medical illness or surgery, trauma, cancer, a history of blood clots or heart failure, and the presence of a pacemaker or central venous catheter, paralyzed extremities, obesity, recent long-distance travel, and sedentary behavior. These patients present with tachycardia, sudden onset of dyspnea, shoulder, back, or chest pain, cough, syncope in patients in whom the clot is larger. And it's always accompanied by some level of anxiety as well. There's also a sense of apprehension, low-grade fever, hemoptysis, leg pain, redness, and unilateral pedal edema, fatigue, cardiac arrest in the worst-case scenario. Treatment should focus on airway, ventilatory, and circulatory support. Any blood that is coughed up should be cleared from the airway, and supplemental oxygen is mandatory. Now let's discuss changes in the cardiovascular system. In terms of anatomy and physiology, a variety of changes occur in the cardiovascular system of a person as they grow older, with the net effect being a decrease in the efficiency of the system overall. The heart hypertrophies with age, probably in response to the chronically increased afterload imposed by stiffened blood vessels. Over time, cardiac output declines, mostly as a result of decreasing stroke volume. Atherosclerosis, which is a disease that causes the arteries to thicken, harden, and calcify, contributes to systolic hypertension, which places an extra burden on the heart. Some changes in cardiovascular performance are probably not a direct consequence of aging, but rather reflect the deconditioning effect of a sedentary lifestyle. Many people tend to limit physical activity and exercise as they grow older. As far as pathophysiology is concerned, with aging, a person's ability to speed up contractions, increase contraction strength, and constrict or narrow blood vessels is decreased because of stiffer vessels. As stroke volume is reduced, cardiac output therefore decreases as well. The heart may lose its ability to raise cardiac output to meet the needs of the body. Geriatric patients are at risk for atherosclerosis along with arterial sclerosis, and atherosclerosis is an accumulation of fat and cholesterol in the wall of the arteries. Some major complications include myocardial infarction and stroke, and it affects more than 60% of people older than 65 years. Atherosclerosis makes stroke, heart disease, hypertension, and bowel infarction more likely. The figure on this slide shows atherosclerosis, which is the buildup of fat and cholesterol in the wall of the artery. And you can see where it has built up, and because the opening is narrowed, the blood tends to accumulate through a more narrow area and can clot. Older people are also at an increased risk for formation of an aneurysm, which is an abnormal blood-filled dilation of the wall of a blood vessel. Severe blood loss can occur when an aneurysm ruptures. The blood vessels then become stiff, which results in higher systolic blood pressure. Other anatomic changes include stiffening and degeneration of the heart valves, which may impede normal blood flow in and out of the heart. Aging also alters the heart's electrical conduction system, and this can cause a heart rate that is too fast, too slow, or too erratic to provide effective blood flow to the body. Orthostatic hypotension is a drop in blood pressure with a change in position. The body is less able to adapt to rapid postural changes. Another vessel-related problem is called venous stasis, and it refers to the loss of proper function of the veins in the legs that would normally carry blood back to the heart. It causes blood clots in the superficial veins, which is called superficial phlebitis, and it also causes blood clots in the deep veins, which is deep vein thrombosis. Deep vein thrombosis can lead to a pulmonary embolism, and people with this condition usually exhibit edema or swelling of the legs and ankles. Eventually, it can cause a reddish-brown discoloration on the skin and in some cases, skin ulcers. Now let's talk about heart attack or myocardial infarction. The classic symptoms of a heart attack are often not present in geriatric patients. Silent, quote-unquote, silent heart attacks are particularly common in women and people with diabetes. Any of the following symptoms may be a manifestation of acute cardiac disease in older patients. This includes dyspnea, epigastric and abdominal pain, loss of bladder and bowel control, nausea and vomiting, weakness, dizziness, lightheadedness, and syncope, fatigue, and confusion. Other signs and symptoms that can indicate a cardiovascular problem include issues with circulation and diaphoresis, which is profound sweating, pale, cyanotic, or mottled skin, and abnormal or decreased breath sounds. It also includes increased peripheral edema, so you need to make sure that you obtain baseline vital signs. This information will provide you with a primary picture of the severity of your patient's condition. You can use these findings to measure it against your ongoing assessment of the patient. Treatment mostly consists of airway, ventilatory, and circulatory support, so make sure to give oxygen and continue to evaluate, and if cardiac problems can be expected to worsen suddenly in these situations, so be prepared. Now let's discuss heart failure. Signs and symptoms will differ depending on the extent to which the right and or left side of the heart is not functioning correctly. Right-sided heart failure occurs when the fluid backs up into the body. You will see jugular vein distension, ascites, and peripheral edema. An enlarged liver may also be present, which is determined by palpation. Right-sided heart failure is often caused by left-sided heart failure, so it is common to see signs of both. With left-sided heart failure, fluid backs up into the lungs. It causes pulmonary edema, and the patient will have severe shortness of breath and hypoxia with crackles in the lungs. Also, you will encounter paroxysmal nocturnal dyspnea, and this is a condition that is characterized by a sudden attack of respiratory distress that wakes the person at night when he or she is breathing, and it's caused by fluid accumulation in the lungs. Patients report coughing, feeling suffocated, and cold sweats, and you will notice tachycardia. If you suspect congestive heart failure, one question you can ask is, do you sleep sitting up? Treatment should consist of airway, ventilatory, and circulatory support. Stroke is the leading cause of death in older people. Let me repeat that. It is a leading cause of death in older people, not the. Preventable risk factors include smoking, hypertension, diabetes, atrial fibrillation, obesity, and sedentary lifestyle. Uncontrollable factors include age, race, and gender. Signs and symptoms include acute altered level of consciousness, numbness, weakness, or paralysis on one side of the body, slurred speech, difficulty speaking, which is aphasia, visual disturbances, headache and dizziness, incontinence, and seizure. And bear in mind, not all of these symptoms will be present in every stroke. You may only have one to a few of these symptoms, but these are all of the possibilities that you may encounter when someone's having a stroke. It depends on what part of the brain is being affected. Hemorrhagic strokes, in which a broken blood vessel can cause bleeding into the brain, are less common and more likely to be fatal. Ischemic strokes occur when a blood clot blocks the flow of blood to a portion of the brain. The treatment goal is to salvage as much of the surrounding brain tissue as possible, as quickly as possible, I might add. Determining the onset of symptoms of stroke is very important. If the symptoms occur within the past few hours, the patient will be a candidate for stroke center therapy. Transient ischemic attack, or TIA, can present with the same signs and symptoms of a stroke. So always manage the patient as if he or she is having a stroke. And the biggest reason for that is because in the field, you do not have the knowledge, expertise, and diagnostic materials and tools to be able to discern a TIA from any other form of stroke. So always manage stroke symptoms the same. There are also changes in the nervous system for geriatric patients. In terms of anatomy and physiology, there are changes in thinking speed, memory, and posture stability, and these are the most common normal findings in older people. The brain decreases in terms of weight from 10 to 20% and volume as a person ages. This increases the amount of space in the cranium, thus increasing the chance for head injuries. Head injuries with minimal mechanism are commonly missed in older patients. There is a 5 to 50% loss of neurons in older people as well. Neurons are responsible for transmission of impulses, so the motor and sensory networks slow down with age. This affects the control rate and depth of breathing, heart rate, blood pressure, hunger, thirst, and body temperature. The performance of most sense organs also declines with increasing age. There are also changes in vision. Visual acuity, depth perception, and the ability of the eyes to accommodate to light change with age. There's also the presence of development of cataracts, which is a clouding of the lenses or their surrounding membranes, and these interfere with vision and make it difficult to distinguish colors and see clearly. There also can be decreased tear production, and this can lead to drier eyes. Older people develop an inability to differentiate colors and have decreased night vision. The inability to see up close is called presbyopia and is caused by a loss of elasticity of the crystalline lens of the eye. A number of other diseases that can plague the night vision or the vision in general of older adults are glaucoma, macular degeneration, and retinal detachment. In relation to hearing, typical hearing problems that cause changes in the inner ear make hearing high-frequency sounds more difficult for some older people. Changes in the ear can also cause problems with balance and make falls more likely. Presbycusis is a gradual hearing loss that occurs as we age. Heredity and long-term exposure to loud noises are the main factors that contribute to hearing loss. When assessing your patient, check for use of hearing aids. And newer ones are small and sit farther into the ear canal, so they aren't as visibly obvious as they used to be. And some patients still wear older models. So make sure you look for newer models that are much smaller and are farther down in the ear canal and aren't so visibly obvious. In relation to taste, the sense of taste can be diminished because of a decrease in the number of taste buds. The negative result might be lessened interest in eating, which can lead to weight loss, malnutrition, and complaints of fatigue. Touch is also effective, and an older person may have decreased sense of touch and pain perception from the loss of end nerve fibers. This loss can create situations in which an older person may be injured and not readily know it. Specifically, there's a decreased sensation of hot and cold. Now let's discuss dementia and the pathophysiology of it. Dementia is the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. It is a chronic, generally irreversible condition that causes a progressive loss of cognitive abilities psychomotor skills, and social skills. Dementia is the result of many neurologic diseases and may be caused by Alzheimer's disease, Parkinson's disease, cerebrovascular accidents, genetic factors. So determining the patient's normal mental status by questioning the family members or friends is appropriate. Also, by evaluating their history, risk factors, and current medications, which can affect mental status. On assessment, the patient might exhibit loss of cognitive function. Patients may have short and long-term memory problems and a decreased attention span, or they may be unable to perform their daily routines. They may also show a decreased ability to communicate and appear confused. Other aspects of dementia can complicate your ability to assess and manage the patient. Sometimes patients are not only confused, but angry as well, and they can have impaired judgment. Sometimes they will be unable to vocalize areas of pain and current symptoms. They may be unable to follow commands. And patients with dementia may express anxiety over movement out of their current residence. You must exercise extreme tolerance and patience. Now let's discuss delirium, which is different than dementia. Delirium is a sudden change in mental status, consciousness, or cognitive processes. It's marked by the inability to focus, think logically, and maintain attention. Delirium affects 15 to 50% of hospitalized people aged 70 years or older. Acute anxiety may be present in addition to other symptoms. Usually memory remains intact. Delirium is generally the result of reversible physical ailments such as tumors or fever or metabolic causes. It can even be brought about by something as simple as a urinary tract infection. Other important things to look for in the history are intoxication or withdrawal from alcohol, withdrawal from sedatives, medical conditions such as urinary tract infections, as I just mentioned, bowel obstructions, dehydration, fever, cardiovascular disease, and hyper or hypoglycemia. Psychiatric disorders such as depression can also be present, and malnutrition or vitamin deficiencies and environmental emergencies. All of these things can bring on delirium. Assess and manage the patient for hypoxia, hypoxovolemia, hypoglycemia, hypothermia. Critical BLS and ALS interventions may include supplemental oxygen, treatment of shock, glucose, and rewarming measures. During the physical examination, you may see changes in circulation, breath sounds, motor function, and pupillary response. Hypotension can indicate hypovolemia. Dilated pupils could suggest hypoxia, and wheezing, crackles, and rhonchi may be present in the lungs. Treatment should include airway, ventilatory, and circulatory support and oxygen with airway adjuncts. Now, syncope is just the medical term for fainting, and this is table 35-2. And with syncope, always assume that this is a life-threatening problem until proven otherwise. The general wisdom is that people don't typically faint for no reason, so especially in geriatric patients, it is wise to assume it's a life-threatening problem until it's proven otherwise. Syncope is often caused by an interruption of blood flow to the brain. An older person who has a period of unconsciousness should be examined to determine the cause of the syncope. Now let's talk about neuropathy. Neuropathy is a disorder of the nerves of the peripheral nervous system in which function and structure of the peripheral motor, sensory, and autonomic neurons are impaired. Symptoms depend on whether the nerves affected are motory nerves, sensory nerves, or autonomic nerves, and where those nerves are located. Motor nerves that are affected can produce by neuropathy can produce muscle weakness, cramps, spasms, loss of balance, and loss of coordination. Sensory nerves affected by neuropathy can result in tingling, numbness, itching, pain, burning, freezing, or extreme sensitivity to touch. Neuropathy of the autonomic nerves can cause changes in blood pressure and heart rate, constipation, bladder, and sexual dysfunction. Now, in geriatric patients, there are also changes in the gastrointestinal system. In relation to the anatomy and physiology, changes in the mouth include a reduction in the volume of saliva with a resulting dryness of the mouth. Dental loss is more widespread in older population and contributes to nutritional and digestive problems. These oral changes increase the risk of choking. Like oral secretions, gastric secretions are reduced as a person ages. Enough acid is still present to produce ulcers under certain conditions. There is also typically a set of changes in gastric motility, and these may lead to slower gastric emptying. The function of the small and large bowel changes little as a consequence of aging. And the incidence of certain diseases involving the bowel, however, increases as a person grows older. So while function remains the same, certain diseases or the appearance of certain diseases can increase as the person grows older. Now let's talk about continued changes in the gastrointestinal system in relation to pathophysiology. Age-related changes in the gastrointestinal or GI system include issues with dental problems, decrease in saliva and sense of taste leading to poor nutrition, poor muscle tone of the smooth muscle sphincter between the esophagus and the stomach that can cause regurgitation and lead to heartburn and acid reflux. A decrease in hydrochloric acid in the stomach can occur, and alterations in absorption of nutrients and slowing peristalsis can be present. There can also be weakening of the rectal sphincter. Changes in the liver predispose older patients to a number of problems as well. The liver, which is responsible for removing toxins and breaking down drugs in the body, shrinks with age. Blood flow to the liver declines, and there is decreased metabolism. This has a direct effect on how medications may affect the patient. GI bleeding issues that may affect older people are GI bleeding that's caused by inflammation, infection, obstruction of the upper or lower GI tract, and it's usually heralded by hematemesis, which is throwing up blood. Bleeding that travels through the lower digestive tract usually manifests as melena, which is black tarry stools. Red blood in the stool usually means a local source of bleeding, such as hemorrhoids. A patient with GI bleeding may experience weakness, dizziness, or syncope. Bleeding in the GI system can be life-threatening. Specific GI problems that are more common in older patients include diverticulitis, which is a condition in which the walls of the gut weaken and small pouches protrude from the colon along those weakened segments. Inflammation develops in one or sometimes more of these pouches. A geriatric patient generally presents with left lower quadrant pain and fever if they have diverticulitis. Bleeding in the upper and lower GI system is what we're going to discuss now. Upper GI bleeding occurs in the esophagus, stomach, or duodenum. Irritation of the lining of the stomach or ulcers can cause forceful vomiting that tears the esophagus. Long-term use of non-steroidal anti-inflammatory drugs, hepatitis, and cancer can contribute to bleeding problems. Lower GI bleeding occurs in the colon or rectum and is brought about by peptic ulcer disease, which is more common in older adults, especially people who use NSAIDs. The patient will complain of a gnawing, burning pain in the upper abdomen that improves after eating but returns later. Complications include bleeding, anemia, and bowel perforation. Gallbladder disease is more common in older adults, and they have a higher risk of complications from gallstones. Patients will present with fever and right upper quadrant pain that may radiate to the shoulder or to the back. It may go from the upper right quadrant and straight through to the back in that very same area, like a line, straight from front to back. Patients may also present with jaundice. With bowel obstruction, the ability of the GI tract to move feces through the system slows with aging, and patients can experience problems having bowel movements. When patients are straining to have a bowel movement, they can stimulate the vagus nerve, which causes a vasovagal response, and that can cause fainting. When assessing patients, ask about NSAID use and alcohol use. Presentation can include pale or yellow thin skin, frail musculoskeletal system, peripheral, sacral, and paraorbital edema, that's puffiness around the eyes or swelling around the eyes, hypertension, fever, tachycardia, and dyspnea. Orthostatic vital signs can help determine if a patient is hypovolemic. Blood pressures and pulse rates are obtained with the patient lying, sitting, or standing. Excuse me. Let me just say that one more time. Blood pressures and pulse rates are obtained with orthostatic vital signs by having the patient measured while lying, measured while sitting, and measured again while standing. Note any drop in blood pressure and increase in heart rate that occurs as the patient moves to an upright position. Do not attempt to assess orthostatic vitals on a patient with obvious signs of shock, hypotension, altered level of consciousness, or possible spinal injury. Treatment consists of airway, ventilatory, and circulatory support, and oxygen should be delivered with adjuncts appropriate to the patient's condition. The acute abdomen, or non-gastrointestinal complaints, is what we're going to discuss now. And abdominal complaints in geriatric patients are extremely difficult to assess. In the pre-hospital setting, the most serious threat from abdominal complaints is blood loss, which can lead to shock and death. Abdominal aortic aneurysms, or a AAA, is one of the most rapidly fatal conditions. A AAA tends to develop in people who have a history of hypertension and atherosclerosis. The walls of the aorta weaken and blood begins to leak into the layers of the vessel, causing the aorta to bulge like a bubble on a tire. If enough blood is lost into the vessel wall itself, shock occurs. If the vessel wall bursts, it rapidly leads to fatal blood loss. A patient with a AAA most commonly reports abdominal pain radiating through to the back with occasional flank pain. If you see or palpate a pulsating mass just above and slightly to the left of the navel, do not continue manipulation or allow other providers to palpate the mass. Treat the patient immediately for shock, including high flow oxygen and thermal regulation, and provide prompt and, might I say, rapid transport to the hospital. Again, obeying all traffic safety laws, but as rapidly as possible, safely. Now, there can also be changes in the renal system. Those are your kidneys and bladder. Changes in the renal system in terms of anatomy and physiology are as follows. The largest component of the urinary system are the kidneys, or renal organs. Age-related changes in the genitourinary system specific to the kidney include a reduction in renal function, a reduction in renal blood flow, and tubule degeneration. Those are the tubules inside the kidney. For the genitourinary system in general, there is generally a decreased bladder capacity, a decline in sphincter muscle control, decline in voiding senses. In other words, they can't tell sometimes if they need to go to the bathroom or not. Increase in nocturnal voiding, benign prostatic hypertrophy, which is an enlarged prostate gland. And the kidneys are responsible for maintaining the body's fluid and electrolyte balance and have important roles in maintaining the kidney's long-term acid-base balance and eliminating drugs from the body. The kidneys decline in weight as a person ages, and renal blood flow decreases by as much as 50%. Now let's talk about the pathophysiology that presents as a result of changes in the renal system. Acute illness in older patients is often accompanied by derangements in fluid and electrolyte balance. Bowel and bladder continence requires anatomically correct GI and genitourinary tracts functioning and intact sphincters and properly working cognitive and physiological and physical functions. Incontinence is not a normal part of aging and can lead to skin irritation, skin breakdown, and urinary tract infections. As people age, the capacity of the bladder decreases, and two major types of incontinence are distinguished: stress and urge. Stress incontinence occurs during activities such as coughing, laughing, sneezing, lifting, and exercise. Urge incontinence is triggered by hot or cold fluids, running water, and sometimes even thinking about going to the bathroom. Treatment consists of medications, physical therapy, and possibly surgery. The opposite of incontinence is urinary retention or difficulty urinating. In men, enlargement of the prostate can place pressure on the urethra, making voiding difficult. Bladder and urinary tract infections can also cause inflammation. In severe cases of urinary retention, patients may experience renal failure. Now, there are also, in geriatric patients, changes in the endocrine system. The anatomy and physiology of the endocrine system is what we're going to talk about now. The endocrine system functions as the control center of the body. A significant change that occurs in an older person is decreased metabolism of thyroxine. Thyroxine affects the body's metabolism, temperature, growth, and heart rate. A reduction in thyroid hormones can cause a condition called hypothyroidism. Most of the signs and symptoms people experience are attributed to the process of aging, and they include a slower heart rate, fatigue, drier skin and hair, cold intolerance, and weight gain. Other endocrine changes include an increase in the secretion of antidiuretic hormones causing fluid imbalance, hyperglycemia, increases in the levels of norepinephrine, and this possibly can have a harmful effect on the cardiovascular system. With the endocrine system in relation to pathophysiology or disorders that you might observe, these include hypersmolar hyperglycemic non-ketonic syndrome, or HHNS, and this is a diabetic complication in older people and occurs more often in people with type 2 diabetes. The signs and symptoms of HHNS and diabetic ketoacidosis often overlap and include hyperglycemia, polydipsia, which is excessive thirst, polyuria, which is excessive urination, polyphagia, which is excessive hunger, dizziness, confusion, altered mental status, and seizures. On assessment, you may see changes in circulation, such as warm, flushed skin, poor skin turgor, pale, dry oral mucosa, a furrowed tongue, and the patient may present with signs and symptoms of hypotension and shock, including tachycardia. The blood glucose level will be valuable in DKA, whereas in HHNS, the value is typically 600 milligrams per deciliter or higher. DKA will present with Kussmaul respirations, while HHNS will not. Assessment of the patient should include obtaining blood pressure, distal pulses, auscultation of breath sounds, temperature, assessment of blood glucose level if it's permitted by local protocol. And treatment should include airway, ventilatory, and circulatory support, and make sure to provide oxygen with adjuncts appropriate to the patient's condition, as we've said in other instances. There are also changes in the immune system as people age. Infections are commonly seen in older people because they generally have an increased risk of infection and are less able to fight infections once they occur. Many older patients may be unable to develop a fever and, in fact, may be hypothermic as a manifestation of severe systemic infection. Anorexia, fatigue, weight loss, falls, or changes in mental status may be the primary symptoms of infection in these patients. Pneumonia and urinary tract infections are common in patients who are bedridden. When infection occurs, signs and symptoms may be decreased or minimized by the patient because of loss of sensation, lack of awareness, fear of being hospitalized. There are also changes in the musculoskeletal system as people get older. In relation to the anatomy and physiology of the musculoskeletal system, aging brings a widespread decrease in bone mass in men and women, but especially among postmenopausal women. Bones become more brittle and tend to break more easily. The discs between the vertebrae of the spine begin to narrow, and they decrease in a height of between 2 inches and 3 inches, and that may occur through the lifespan, along with changes in posture. Joints lose their flexibility and may be further immobilized by arthritic changes. A decrease in the amount of muscle mass often results in less strength. The pathophysiology findings you may have in the musculoskeletal system of geriatric patients include the following. Changes in physical abilities can affect older adults' confidence in their mobility. So muscle fibers also become smaller and fewer, and motor neurons decrease in number. Strength declines, and ligaments and cartilage of the joints lose their elasticity, and cartilage goes through a basic degenerative change. The stooped posture of older people comes from atrophy of the supporting structures of the body. 2 of every 3 older patients will show some degree of kyphosis. Loss of height in older adults generally results from compression in the spinal column. You'll also see, as far as pathophysiological change, the presence of osteoporosis, which is a condition that affects men and women and is characterized by a decrease in bone mass leading to reduction in bone strength and greater susceptibility to fracture. The extent of bone loss that a person undergoes is influenced by numerous factors, including genetics, smoking, level of activity overall, diet, alcohol consumption, hormonal factors, body weight. And the most rapid loss of bone occurs in women during the years following menopause, and that's due to a drop in estrogen. Many postmenopausal women use hormone replacement therapy as a means to reduce the loss of bone because of lower estrogen levels. So replacing the estrogen helps minimize, reduce, and can sometimes even stop loss of bone or prevent it outright. Patients may also take calcium and vitamin D supplements, and these are another treatment for the condition of osteoporosis. And there are many other medications available as well to improve bone strength. Osteoarthritis is a progressive disease of the joints that destroys cartilage, promotes the formation of bone spurs in joints, and leads to joint stiffness. It results from wear and tear, and in some cases from repetitive trauma to the joints, and affects 35 to 45% of the population older than 65 years of age, from minimally to very severely. And Osteoarthritis affects several joints of the body, most commonly those in the hands, knees, hips, and spine. Patients complain of pain and stiffness that gets worse with exertion, and patients are typically treated with anti-inflammatory medications and physical therapy. There are also changes in the skin that occur as people age. The proteins that make the skin pliable decline with age, and the layer of fat under the skin also becomes thinner because of the redistribution of fluids and proteins. Bruising becomes more common because the skin can tear more easily, and the blood vessel and deeper layers of the skin just from a slight bump tear and bleed under the skin a little more easily. Also, exocrine or sweat glands do not respond as readily to heat because of atrophy and changes to the tissues of the dermal layer of the skin. Another problem that affects the skin is pressure ulcers, sometimes referred to as bed sores or decubitus ulcers. The pressure from the weight of the body cuts off blood flow to an area of the skin, and with no blood flow to the skin, a sore will develop. To prevent these ulcers, take special care to pad under any bony prominences and in the voids in a patient who may be immobilized for an extended period. So pad underneath the lower back and behind the neck, behind the knees, under the elbows, etc. Places where they'll have protuberances or natural voids like the curvature of the spine, normal curvature of the spine. You may also see ulcers in the following various stages of development, Stage 1 in an ulcer will present with non-blanching redness with damage under the skin. Stage 2 may appear as a blister or an ulcer that can affect the dermis and epidermis. Stage 3 can be deeper and be an invasion of the fat layer through to the fascia. Stage 4 is an invasion all the way to the muscle or bone. Decubitus ulcers can be painful and cause complications such as bleeding, sepsis, and bone inflammation or bone infection called osteomyelitis. Now let's discuss toxicology. Older people are more susceptible to toxicity because of decreased kidney function, altered GI absorption, decreased vascular flow in the liver, and the kidneys may undergo many changes with age. And decreased liver function makes it harder for the liver to detoxify blood and eliminate substances such as medications and alcohol. These metabolic issues can also make it difficult for physicians to find appropriate dosage for new medications. Typical over-the-counter medicines used by older people include aspirin, antacids, cough syrups, and decongestants. Many people believe over-the-counter medications cannot be dangerous. They're still drugs. They just aren't controlled by a prescription. And many of these medications can have negative effects when mixed with one with the other, and or with herbal substances, alcohol, and other prescription medications. Polypharmacy refers to the use of multiple prescription medications by one patient. Patients may not remember what medications one doctor prescribed or may not want to tell one doctor about seeing another. These negative effects can include overdosing and negative medication interaction. Both overdose and underdose can lead to serious problems. Medication noncompliance in older patients is also an issue, and it may occur because of financial challenges, the inability to open containers, and they're embarrassed to ask for help with that sometimes, impaired cognitive, vision, and hearing ability. There also can be behavioral emergencies in older people just like anyone else, but We'll see behavioral emergencies in older people, and they can suffer from depression. And depression is not a part of normal aging, but it's rather a medical disease. And this common, often debilitating psychiatric order affects millions of older Americans. In contrast with the normal emotional experiences of sadness, grief, loss, and temporary bad moods, depression is an extreme and persistent problem, and it can interfere significantly with an older person's ability to function. Depression is treatable with medication and therapy, and if depression goes unrecognized or is untreated, is unfortunately often associated with a higher suicide rate in the geriatric population than with any other age group. Risk factors for depression include a history of depression, chronic disease, loss. The following conditions contribute to the onset of significant depression. Those include substance abuse, isolation, prescription medication use, chronic medical conditions. And treatment of severe depression in older adults usually consists of behavioral counseling, medication, or a combination of both. Now, let's discuss suicide among older Americans. Most older adult suicide victims have been recently diagnosed with depression and have seen their primary care physician within the month before the actual event. Older men have the highest suicide rate of any age group in the United States. At highest risk are white men aged 85 years and older who use firearms as their suicide method of choice. Older persons who attempt suicide choose much more lethal means than younger victims and generally have diminished recuperative capacity to survive a suicide attempt. Unlike younger people, geriatric patients typically do not make a suicidal gesture or an attempt to get help, but just carry it through to the end. Instead, as I was just saying, the rate of actual completed suicide is disproportionately high in the geriatric population. Many geriatric patients see no other way out when they have a terminal illness or a debilitating cardiac or neurologic condition, such as severe heart disease or stroke. Some common predisposing events and conditions that lead to suicide include death of a loved one, physical illness, a sense of depression or actual depression and a sense of hopelessness along with it, alcohol abuse, alcohol dependence, and loss of meaningful life roles. When assessing the patient who is displaying signs of depression, it is appropriate to ask if he or she is considering suicide. If the answer is yes, the next question should be, do you have a plan? Make sure to include this information in your report. Now let's talk about the GEMS diamond, GEMS or GEMS diamond. The GEMS diamond was created to help you remember what is different about older patients. It is not intended to be a format for the approach to geriatric patients, nor is it intended to replace the ABCs of care. Instead, it serves as an acronym for the issues to be considered when assessing every older patient. The G stands for geriatric patient. Consider that older patients are different from younger patients and may present atypically. Be familiar with the normal changes of aging, all the things we've been discussing, and treat older patients with compassion and respect. The E stands for an environmental assessment. Assessing the environment can help give clues to the patient's condition and the cause of the emergency. Preventative care is very important for a geriatric patient who may not carefully study the environment or may not realize where risks exist. The M stands for medical assessment. Older patients tend to have a variety of medical problems and may be taking numerous prescription, over-the-counter, and herbal medications. Obtaining a thorough medical history is very important. S stands for social assessment. Older people may have less of a social network because of the death of a spouse, family members, and friends. Older people may also need assistance with activities of daily living. Consider obtaining information pamphlets about some of the agencies for older people in your area. There are special considerations you need to bear in mind when assessing a geriatric medical patient. Assessing an older person can be challenging because of communication issues, hearing and vision deficits, alteration in consciousness, complicated medical histories, and effects of medication. When doing your scene size up, always remember, first and foremost, scene safety. And geriatric patients are commonly found in their own homes, retirement homes, or skilled nursing facilities. Many older people do live alone. Access to them may be hampered if their condition prevents them from getting to the door. Police or fire department assistance may be required to gain access to the residence. Many older people try to maintain their independence as long as they can. You need to take note of negative or unsafe environmental conditions. Look for clues that might explain the patient's medical history or current problem. In a nursing home or residential care facility, you will need to locate the patient's room and find a staff member who can explain why you were called. In any case in which the patient's mental status is altered, you need to find someone who can tell you the patient's history and whether the patient's behavior or level of consciousness is normal or altered. Let's discuss mechanism of injury and nature of illness. The NOI, or nature of illness, may be difficult to determine in older people who may have an altered mental status or dementia. You must ask a family member, caregiver, or bystander why he or she called. There can also be multiple and chronic disease processes that may also complicate determination of the nature of an illness. Complaints from an older person may be vague. Chest pain, shortness of breath, and an altered level of consciousness should always be considered serious, however. When doing your primary assessment, address life threats, determine the transport priority of your patient based on his or her condition, and maintain a high index of suspicion for serious injuries, even with mechanisms of injury that might seem minor in younger patients. As you approach the patient, you should be able to tell if the patient is generally in stable or unstable condition. Use the AVPU scale to determine the patient's level of consciousness. Assessment of airway and breathing. Anatomic changes that occur as a person ages predispose geriatric patients to airway problems. Aging and disease can compromise a patient's ability to protect his or her airway with a loss of gag reflex and normal swallowing mechanisms. Changes in level of consciousness, dementia, and post-stroke weakness or paralysis can cause airway obstruction or aspiration. Ensure that the patient's airway is open and not obstructed by dentures, vomitous fluid, or blood. Suction may be necessary. Anatomic changes also affect a person's ability to breathe effectively, including increased chest wall stiffness, brittle bones, weakening of the airway musculature, decreased muscle mass, and loss of mechanisms that protect the upper airway, such as cough and gag reflexes, and that can cause a decreased ability to clear secretions. A decrease in the number of cilia that line the bronchial tree results in the inability of the patient to remove material from the lung, which can cause infection. In some patients, the alveoli are damaged, and a lack of elasticity results in a decreased ability to exchange oxygen and carbon dioxide. Airway and breathing issues should be treated with oxygen as soon as possible. In regards to circulation, poor perfusion is a serious issue in an older adult. Physiologic changes may negatively affect circulation. Less responsive nerve stimulation may lower the rate and strength of the heart's contractions, and lower heart rates and weaker irregular pulses are common in older patients. There are also vascular changes and circulatory compromise that might make it difficult to feel a radial pulse in an older patient. Circulation problems in older adults should be treated with oxygen as soon as possible. Determine if cardiac abnormalities in an older patient indicate an acute emergency or a chronic condition, and acute emergencies should be managed rapidly, as always, in any patient. So you need to make sure you work to discern chronic condition from acute emergency. And there may be situations where they are ultimately linked, and you may or may not know that in the field. As far as transport decisions, patient assessment is more complicated in an older adult, and multiple problems can exist. Any complaints that compromise airway, breathing, or circulation should result in the transportation of the patient as a priority patient. Your most important task is to determine conditions that are life-threatening, treat them to the best of your ability, and provide transport to priority patients. Priority patients include patients who have poor general impression overall, airway or breathing problems, acute altered level of consciousness, shock, severe pain, uncontrolled bleeding, and older people who do not have the reserves that younger people do, and they will easily decompensate. So make sure you're alert to sudden rapid change in your patient or decompensation. With history taking, make sure to investigate the chief complaint. Find and account for all medications. Communication may be more complicated with an older adult, but it is critical that you obtain a thorough patient history. The determination should be made early on as to whether the altered level of consciousness is acute or chronic. Chronic mental status impairment is not a normal process of aging, but is caused by a pathologic or disease process. You should never accept confusion as normal. Older people may not show severe symptoms even if they are very ill. Multiple disease processes and multiple and/or vague complaints can make assessment complicated. Make sure to ask questions to assess the nature of the problem and determine whether it may or may not be life-threatening. Take a full set of vital signs. Ask what is normal, quote unquote, for that patient. With sample history, you may have to rely on a relative or caregiver to help you in collecting a sample history. Note signs you can observe and your general impression. Make sure you have a list of the patient's medications or take the medications with you to the hospital if possible. The last meal is particularly important in a patient with diabetes, but negative nutrition can have a negative effect on a patient overall. It is advantageous to provide transport to a facility that knows the patient's medical history. With secondary assessment, it may be performed on scene, en route to the emergency department, or not at all. With physical examinations, your older patient may not be comfortable with being exposed, so make sure to protect his or her modesty, as you should really in any patient, but sometimes older people are even more modest. Consider the need to keep your patient warm during the exam as well. With vital signs, the heart rate should be in the normal adult range, but may be compromised by medications such as beta blockers. Weak and irregular pulses are also common in older patients. Circulatory compromise may make it difficult to feel a radial pulse in an older patient, and other pulse points may need to be considered, such as a pedal pulse point. Blood pressure tends to be higher in older people. Capillary refill is not a good assessment because of skin changes and reduced circulation to the skin. The respiratory rate should be in the same range as an older adult, but remember that chest rise and fall will be compromised by increased chest wall stiffness. Be sure to auscultate breath sounds to listen for crackles associated with pulmonary edema, rhonchi or rattles associated with pneumonia, wheezes associated with asthma, and also with monitoring devices, make sure to use careful interpretation of pulse oximetry data And this is necessary in older adults because the pulse oximetry device requires adequate perfusion to get an accurate reading, and they may not have very good perfusion to like a fingertip pulse oximeter, for example. Adhesive probes might help to confirm accuracy of the data that you're seeing on a regular pulse ox device. Determine what the patient's normal blood pressure is, your baseline blood pressure, and any change from the patient's normal baseline can alert you to a potential problem. With reassessment, reassess the geriatric patient often because of the condition of an older adult may deteriorate quickly. Reassess vital signs, reassess the patient's complaint, and recheck interventions. Also identify and treat changes in the patient's conditions that may appear. As far as interventions, accommodate positioning requests when possible, especially when the patient is experiencing shortness of breath. Allow the patient to maintain a position of comfort unless contraindicated. Assist ventilation as needed. Administer glucose for a patient with diabetes who has altered mental status and manageable airway. In specific cases, you may also assist with nitroglycerin, aspirin, or inhalers. And pharmacologic interventions do require medical direction and are based on local protocols. So make sure you know your protocols for your area and what you're licensed and approved to do and not do. Administration of oxygen may be a useful therapy for many geriatric problems. Be mindful of monitoring the level of consciousness in a patient with COPD. Be prepared to ventilate if breathing becomes inadequate, and listen to your patient, respond to your patient, and provide reassurance. With communication and documentation, communicate your findings and the interventions you used to emergency department personnel. Document all history, medication, assessment, and intervention information. The table on this slide provides guidelines for assessing geriatric patients. Take the time to review this table. This is 35-4, and this is a good broad set of assessment guidelines. In regards to trauma in geriatric patients, in general, the risk of serious injury or death is more common in older patients who experience trauma than in younger patients. Conditions that create risk and complicate the assessment of geriatric patients include slower homeostatic compensatory mechanisms, limited physiologic reserves, normal effects of aging on the body, and existing medical issues. Physical findings in an older adult may be more subtle and more easily missed. The mechanisms that cause serious injury in older people are usually much more minimal than in younger people. Recuperation from trauma is longer and less successful in older people. Many injuries in older people are under-triaged and undertreated. Because of changes in the body, older pedestrians are more likely to have life-threatening complications after being struck by a vehicle. Older pedestrians commonly suffer injury to the legs and arms. Other injuries can be caused by secondary collision onto the street, often involving the head. Older people are also more likely to experience burns because of altered mental status, inattention, and a compromised neurologic status. Risk of mortality from burns is increased when pre-existing medical conditions exist, the immune system is weakened, fluid replacement is complicated by renal compromise. There is mortality from penetrating trauma in older adults, especially in the case of a gunshot wound. Penetrating trauma can easily cause serious internal bleeding. Falls are the leading cause of fatal and non-fatal injuries in older adults. Nearly half of fatal falls in geriatric patients result in traumatic brain injury. Anatomic changes and trauma. There can be changes in pulmonary, cardiovascular, neurologic, and musculoskeletal systems that the result of trauma make older patients more susceptible to sustained recovery or non-recovery from trauma. The brain shrinks, leading to a higher risk of cerebral bleeding following head trauma. Skeletal changes cause curvature of the upper spine, which is kyphosis, that often requires additional padding during spinal immobilization. There can also be loss of strength, sensory impairment, and medical illness, and all of those can increase the risk of falls. A geriatric patient's overall physical condition may lessen the ability of the patient's body to compensate for the effects of even simple injuries. A geriatric patient's blood pressure drops sooner than in a younger adult patient during a traumatic emergency, so make sure you're conscious of that. As a result of bone loss from osteoporosis, older patients of both sexes are prone to fractures, especially of the hip. Hip fractures are much more common among women. Contributing factors include stresses of ordinary activity, a standing fall, vitamin D and calcium deficiencies, metabolic bone disease, and tumors. And injuries to the hip tend to be recurring. Older patients with osteoporosis are also at risk for pelvic fractures. Recovering from these kinds of injuries can be complicated for an older person. With age, the spine stiffens as a result of shrinkage of disc spaces, and vertebrae become more brittle. Compression fractures of the spine are also more likely to occur. Because brain tissue shrinks with age, older patients are more likely to sustain closed head injuries such as subdural hematomas. Acute subdural hematoma are among the deadliest of all head injuries. Tiny veins between the surface of the brain and its outer covering stretch and tear, allowing blood to collect, and this puts pressure on the brain itself. Blood fills the skull very rapidly, compressing the brain tissue, as I just mentioned, which often results in brain injury. Serious head injuries are often missed because in older patients, the mechanism may seem relatively minor. But if you think about the overall brain being less volume, well, their skull didn't shrink along with it. So a bump on the head causes much more dramatic movement of the brain inside the skull than in a younger person where they still have larger brain capacity and volume. Other factors that predispose an older patient to serious head injury include long-term abuse of alcohol, recurrent falls or repeated head injury, and anticoagulation medications. As far as environmental injuries, internal temperature regulation slows with aging owing to a slowed endocrine system, as we discussed before, slowed circulation, and decreased sweat production in the skin. Chronic disease, medication use, and alcohol use. And half of all deaths from hypothermia occur in older people. Most indoor hypothermia deaths involve geriatric patients. Living where harsh winters occur is a risk factor. The house is cold and they don't realize it, and they don't put on that extra sweater or an extra blanket or bump up the thermostat. Hypothermia can also develop at temperatures above freezing when an older person is exposed for a prolonged period. Death rates from hyperthermia more than double in older people compared with younger people. People older than 85 years are at highest risk. And this is when their endocrine system isn't working well and their sweat glands aren't working as well, so they don't sweat, and their body temperature, core body temperature, can jack straight up and put them at serious risk. And it's that decrease in sensitivity to temperature, both cold and hot, is why on a hot day you'll see your grandmother sitting in a sweater, and or you might come across a patient who is wrapped heavily and it's a warm day outside. So that's something that you will probably see at some point. Be aware of the environment and how they're dressed in relation to it. Special consideration in assessing geriatric trauma patients Trauma is never isolated to a single issue when you're assessing and caring for a geriatric patient. As far as scene size up, scene safety, again, is always your first consideration. Take standard precautions. Consider the number of patients. Determine if you need additional or specialized resources. Mechanism of injury and nature of illness. When it's considered, you need to look for clues that indicate whether your patient's traumatic incident may have been preceded by some medical incident. Bystander information may be available to help you determine if a loss of consciousness occurred. MOI is important in establishing whether an injury is considered critical, and it affects treatment and transport considerations. With primary assessment, assess life threats and address them. Determine the transport priority of the patient, and it's recommended that older trauma patients be transported to a trauma center. Form a general impression. As you approach the patient, you should be able to tell if he or she is generally in stable or unstable condition. Determining neurologic status may be difficult if you do not know the patient's baseline. Try to get information from someone familiar with the patient if possible. Use the AFPU and Glasgow Coma Scale to determine mental status. An important consideration with any patient is the inability to remember the event itself. With airway and breathing in geriatric trauma, if the patient's talking to you, their airway is naturally patent. Patients who have noisy respirations have some sort of airway compromise. With older patients, they may have a diminished ability to cough, so suctioning is important. And assess for the presence of dentures, but do not remove them unless they are creating an airway patency problem. In an unresponsive patient, open the airway with a modified jaw thrust maneuver. Perform a thorough respiratory assessment and physical assessment of the chest and treat accordingly. With circulation in a geriatric trauma patient, manage any external bleeding immediately. Drinking alcohol and taking anticoagulation medications can make internal bleeding worse or external bleeding more difficult to control. Physiologic changes secondary to aging can worsen the effects of trauma dramatically. Older people do not heal from trauma as easily as younger adults, as we mentioned before. And older patients can more easily go into shock. Patients who were hypertensive prior to injury may have a normal blood pressure when they are actually in shock. So that's something very important and a distinction between geriatric and normal younger adults to bear in mind. With history taking, make sure to investigate the chief complaint. Considerations in your assessment of the patient's condition and stability must include past medical conditions, even if they are not currently acute or symptomatic. With secondary assessment, physical examination should be performed on a geriatric trauma patient in the same manner as for any adult, but with consideration of the higher likelihood of damage from trauma. Any head injury can be life-threatening in an older adult. When examining the chest, consider that breathing may be impaired. Check lung sounds and look to see if there is any evidence of pacemakers or previous cardiac surgery. Decreased muscle size in the abdomen may mask abdominal trauma. Look for bruising and other evidence of trauma. Injury to the liver or spleen may present with diffuse abdominal pain, or pain may refer to the left shoulder. With vital signs in a geriatric trauma patient, assess the pulse, blood pressure, and skin signs. And remember, capillary refill is unreliable in older people because of compromised circulation. Remember that some older people take beta blockers, which will inhibit their heart from becoming tachycardic, which you would normally expect to see in shock. With the reassessment for geriatric trauma, repeat the primary assessment and remember that a geriatric patient has a higher likelihood of decompensating after trauma. Interventions with trauma in geriatrics Let's talk about broken bones. And broken bones are common, and they need to be splinted in a manner appropriate to the injury. With the effective application of conventional splint and backboard may be difficult or impossible unless a large amount of padding is used. Trying to force a patient into a normal anatomic position can harm the patient. If somebody's got kyphosis, or what is poorly referred to as a hunchback, or lowering, posture where their head's lower to the ground, trying to force them to lay flat and hard on a backboard is cruel and unusual punishment and can cause physical harm. So bear, these types of changes in mind when you're trying to splint or backboard an older patient with conditions that could be present, both seen and unseen. In hip and pelvic fractures, avoid long rolling the patient. In general, padding should be done for comfort and help decrease the likelihood of decubitus ulcers forming. Provide blankets and heat to help prevent hypothermia. With communication and documentation of geriatric trauma patients, remember, just as we talked about before, communication with older people can be challenging. So make sure to remember that. Also provide physiological support as well as medical treatment, and document assessment, treatment, and reassessment, including any changes in the patient's status. With assessment of falls, falls can be caused by a medical condition such as fainting, a cardiac rhythm disturbance, or a medical interaction. Whenever you assess a geriatric patient who is falling, it is important to find out why the fall occurred. Consider that the fall may have been caused by a medical condition, so look carefully for clues from the patient, bystanders, and the environment. Consider that if a medical condition caused the fall, it may be life-threatening. Responding to nursing and skilled care facilities. With many of your geriatric patients with whom you interact, the call will occur at a nursing home or another skilled care facility. The kind of facility will depend on the type of care that patient has been in need of. Nursing homes are facilities that serve patients who need 24-hour care and are sometimes a step down from an acute care hospital. Patients require assistance with daily living and need therapeutic or rehabilitation services. Calls to these types of facilities can sometimes be challenging. Patients often have an altered level of consciousness and may not be able to give you a nature of illness or mechanism of injury. The staff is usually spread thin, so that's one thing to bear in mind. The most important piece of information you need to establish immediately is what is wrong with the patient that is new or different today that made you call 911. Talk to the staff who directly care for the patient on a daily basis. With potentially limited information, you need to do an assessment to determine if the patient's problem is life-threatening and or requires ALS level care. Infection control needs to be high priority for EMTs when visiting these facilities. Good hand washing and standard precautions can inhibit the spread of infectious pathogens to people who already have compromised immune systems. An infection in an older patient can lead to life-threatening sepsis. There are many risks to the patients and the EMTs. Methicillin-resistant Staphylococcus aureus, more commonly known as MRSA infections, are common among people who are living in close quarters, such as nursing homes. This organism can be found in decubitus ulcers, on feeding tubes, and on indwelling urinary catheters. They can cause mild infections on the skin or invade the bloodstream, lungs, or urinary tract. It's primarily spread by broken skin-to-skin contact, but is also acquired by touching objects that have the bacteria on them. That bacteria can live a long time outside the body. Make sure to protect yourself and reduce the spread of MRSA infections by washing your hands before and after every patient contact, and properly dispose of or disinfect all medical equipment and take appropriate standard precautions with every patient. Many infections in hospitals are caused by vancomycin-resistant enterococci, which is VRE. Enterococci are bacteria that are normally present in the human intestines and the female reproductive tract. Some of the enterococci have become resistant to antibiotic commonly used to treat these infections, which is called vancomycin. Clostridium difficile is a bacterium that is responsible for the most common cause of hospital-acquired infectious diarrhea. It is a bacterium that normally grows in the intestines. Healthcare workers may carry this bacterium following contact with contaminated feces, and it can also be found on environmental surfaces such as furniture, floors, toilets, sinks, bedding, and symptoms can range from minor diarrhea to a life-threatening inflammation of the colon. Typical alcohol hand-based sanitizers do not inactivate or kill C. difficile. Contact precautions with gowns and gloves and hand washing with soap and water after each and every patient contact is essential to prevent transmission. So you'll see this particular organism referred to as Clostridium difficile or C. difficile. With dying patients, let's discuss this. As older patients are living longer, more terminally ill patients are choosing to die at home rather than in a hospital. Often the patient comes to terms with his or her impending death before the family does. Dying patients receive what is called palliative or comfort care. Palliative care recognizes that death is a normal part of the life cycle. It does not hasten or prolong death, but focuses on relieving pain and providing emotional support and comfort for the patient and his or her loved ones. Your interaction with a dying patient will have a long-term effect on the family, so be understanding, sensitive, and compassionate. Determine if the family wishes for the patient to go to the hospital or stay in the home. Let's discuss advance directives. Advance directives are specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to patients who cannot speak for themselves. Dealing with advance directives has become more common for EMS providers because more people are electing to choose hospice services and spend their final days at home. Advance directives may take the form of a do not resuscitate order, DNR order. A DNR order gives you permission not to attempt resuscitation for a patient in cardiac arrest. For a DN order to be valid, the form must be signed by the patient or legal surrogate and by one or more physicians or other licensed healthcare providers. It's generally notarized as well. A DNR does not mean do not treat. If the patient is still alive, you are obligated to provide supportive measures that may include oxygen delivery, pain relief, and comfort. Basic airway breathing and circulatory support should be provided. Cardiopulmonary resuscitation may not be provided. A healthcare power of attorney is an advance directive that is exercised by a person who's been authorized by the patient to make medical decisions for him or her. When transporting patients from nursing facilities, consider the following general guidelines. Patients have the right to refuse treatment, including resuscitative efforts, provided they are able to communicate their wishes. A DNR order is valid in a healthcare facility only if it is in the form of a written order by a physician. You should periodically review state and local protocols and legislation regarding advance directives. When you are in doubt or when there are no written orders, you should try to resuscitate the patient. Elder abuse and neglect. Elder abuse is defined as any action on the part of an older person's family member, caregiver, or other associated person that takes advantage of the older person's property, person, or emotional state. Abuse can result from acts of commission, In other words, these are words or actions that cause harm, such as verbal, physical, or sexual assault. Abuse can also result from acts of omission, which is failure to act, such as denying an older person adequate nutrition or medical care. The exact extent of elder abuse is sadly not known for several reasons, including the following. Elder abuse is a problem that has been largely hidden from society. The definitions of abuse and neglect among the geriatric population vary. Victims of elder abuse are often hesitant to report the problem to law enforcement agencies or human and social welfare personnel. The abused person may feel traumatized by the situation or be afraid that the abuser will punish him or her for reporting the abuse. The abused person may be frail and have multiple chronic medical conditions or dementia. Elder abuse occurs most often in women older than 75 years. The physical and emotional signs of abuse, such as rape, spouse beating, and nutritional deprivation, are often overlooked or not accurately identified and sadly not taken seriously. Older women in particular are not likely to report incidents of sexual assault to law enforcement agencies. Patients with sensory deficits, dementia, and other forms of altered mental status may not be able to report abuse. Abusers of older people are sometimes products of child abuse themselves, and the abuse that is inflicted on the older person may be retaliatory. Most of these abusers are not trained in the particular care that older people require and have little relief time. Their lives are now significantly complicated by the constant demanding needs of the older person that they have to care for. The abuser may also have marked fatigue, be unemployed with financial difficulties, or abuse one or more substances. Environments such as nursing, convalescence, and continuing care centers are also sites where older people sustain physical, psychological, financial, or pharmacologic harm. Often, care providers in these environments consider older people to be management problems or categorize them as obstinate and undesirable patients. Consult local authorities, but in general, you should assume that you have the same obligation to report suspected elder abuse as you would suspected child abuse. Notify receiving hospital personnel of your concerns and report to the proper authorities based on your local protocols. Factually document your findings. You must document them. With assessment of elder abuse, take note of the environment and conditions that a patient lives in and of soft tissue injuries that cannot be explained by the person's lifestyle and physical condition. You should suspect abuse when answers to questions about what caused the injury are concealed or avoided. Suspect abuse also when you are given unbelievable answers. If it's too good to be true, or too unbelievable to be true, then that's probably the case. Information that may be important in assessing possible abuse includes the following: caregiver apathy about the patient's condition, overly defensive reaction by a caregiver to your questions, the caregiver does not allow the patient to answer the questions but interjects themselves, and repeated visits to the emergency department or clinic with a history of being quote-unquote accident prone, soft tissue injuries, unbelievable, vague, or inconsistent explanations of injuries. Now, there may also be psychosomatic complaints, chronic pain without medical explanation, self-destructive behavior, eating and sleep disorders, depression and lack of energy, substance and or sexual abuse history, and many patients who are being abused are so afraid of retribution that they make false statements. Repeated abuse can lead to a high risk of death. A preventative measure in reducing additional maltreatment of the patient is identification of the abuse. This is Table 35-5, and these are categories of elder abuse. There can be signs of physical abuse, and these injuries may be the result of acute or chronic abuse or neglect. Inflicted bruises are usually found on the buttocks and lower back, genitals and inner thighs, cheeks or earlobes, neck, upper lip, inside the mouth, and pressure bruises may be caused by the human hand and may be identified by oval grab marks, pinch marks, or outright handprints. Human bites are typically inflicted on the upper extremities and can cause lacerations and infection. Inspect the patient's ears for indications of twisting, pulling, or pinching, and evidence of frequent blows to the outer ears. Investigate multiple bruises that are in various states of healing. Typical abuse from burns is caused by contact with cigarettes, matches, heated metal, forced immersion in hot liquids, chemicals, electrical power sources. Observe the patient's weight and try to determine whether he or she appears undernourished or has been unable to gain weight in the current environment. Check for signs of neglect, such as evidence of lack of hygiene, poor dental hygiene, poor temperature regulation, lack of reasonable amenities in the home. Regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. Geriatric patients with altered mental status may never be able to report sexual abuse. Many women do not report cases of sexual abuse because of shame and the pressure to remain silent, and honestly, they don't think anyone will believe them, as I stated earlier. Okay, let's review. There's an awful lot to take in, just like there was a lot of separate treatment regarding pediatric patients in terms of treatment and also their physiology and pathophysiology, and infants are a whole nother category. So are geriatric adults. So let's review everything that we covered in this chapter. Question number 1, the least common cause of death in patients over 65 years of age is stroke, diabetes, heart attack, or drug overdose. If you think about the most common types or causes of death for patients over 65 that we talked about, you should be able to pick out which is listed here and is the least common cause of death in patients over 65. And the correct answer is D. The leading causes of death in patients over 65 years of age are heart disease, diabetes, stroke, cancer, pulmonary diseases, and trauma. Drug overdose, intentional or unintentional, is not a leading cause of death in this age group. And since we've covered stroke, diabetes, and heart attack as the most common causes of death, that's what is listed here. And drug overdose is the correct answer. It is the least common cause of death in patients over 65. Question 2. According to the GEMS diamond, a person's activities of daily living are evaluated as the A. Sample history, B. Social assessment, C. Medical assessment, or D. Environmental assessment. You should be able to get this one with relative ease. It is B. The GEMS diamond was created to help you remember what is unique to older people. During the social assessment, the S in the GEMS diamond, the patient's activities of daily living, such as eating, dressing, bathing, and toileting, are evaluated. Are these activities being provided? If so, by whom? Are there delays in obtaining food, medication, or other necessary items? So here we're discussing just the S in the GEMS diamond as an example of one letter of the acronym. So remember that total definition of the GEMS diamond, make sure to review it in your text or on the slides here where we discussed it earlier. And remember that it is unique to helping you remember what you will find in older patients. Let's look at the incorrect answer. According to the GEMS diamond, a person's activities of daily living are evaluated during the sample history. Incorrect. B, during the social assessment, or S, letter of the GEMS diamond. That is the correct answer, B. C, medical assessment. M is obtained by a thorough medical history. It is important and completed before the social assessment. And E is the assessment of the environment. It considers that the home is well kept, too hot, too cold, or poses any hazards. So, if you read this question carefully, it is asking you about specifically the S in GEMS here. 3, a condition that clouds the lens of the eye is called an A, cataract, B, nystagmus, C, astigmatism, or D, glaucoma. It is A. Most people know this, and as people get older, cataracts or clouding of the lens of the eye may interfere with vision. Glaucoma is a condition caused by increased intraocular pressure. Nystagmus is characterized by involuntary movement of the eye, and astigmatism is an optical defect that causes blurred vision due to the inability of the eye to focus an object into a sharp focus image on the retina. And we've gone over all the incorrect answers already. So, like I said, most people commonly know what a cataract is. That is a condition that clouds the lens of the eye. And fortunately now we have inexpensive and very effective surgery to literally replace the lens in the eye. Number 4, you are called to a neatly kept residence for an 80-year-old woman who lives by herself. She burned her hand on the stove and experienced a full thickness burn. When treating this patient, it is important to note that A, there is a high likelihood she has been abused. Remember to look at the environment here. It's a neatly kept residence. B, isolated full thickness burns to the hand are not critical burns. C, this patient should probably be placed in an assisted living center. Or D, slowing reflexes caused a delayed pain reaction in older people. Read everything in this question and you'll get this answer easily. And it is D. In older patients, the sense of touch decreases due to a loss of end nerve fibers, more commonly referred to as a reduction in the sense of touch. This loss, in conjunction with slowing of peripheral nervous system, causes a delayed reaction to pain. In this particular scenario, there's no indication the patient's been abused. Partial and full thickness burns to the hands, feet, face, and genitalia, as you know from studying burns earlier, are considered critical burns, regardless of the patient's age. Let's look at the incorrect answers. You're called to a neatly kept residence for an 80-year-old woman who lives by herself. She burned her hand on the stove and experienced a full thickness burn. When treating this patient, it is important to note that A, there's a high likelihood she's been abused. There's no indication of that in this particular scenario. B, isolated full thickness burns to the hand are not critical burns. Well, you know from studying burns, of course they are. A full thickness burn is critical, absolutely critical. And I might footnote that in an older person who cannot regulate their body temperature as well, who's rapidly losing heat through a full thickness burn, it can cause onset of shock a lot sooner, as well as a rapid drop in body temperature. So that's something to bear in mind with burns in older patients, just like burns in children whose sweat glands haven't developed yet. C, this patient should probably be placed in an assisted living center. Everybody burns themselves at some point, hopefully not this badly, but just because you injure yourself and you're older doesn't mean you need to be placed in an assisted living center. Yes, she burned herself badly, but doesn't mean she can't take care of herself. And of course we went over D, which is the correct answer. Number 5, the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function is called, remember this is the slow onset of it, this is called A, senility, B, delirium, C, dementia, or D, delusion. We spent quite a bit of time differentiating between these, a couple of these especially, so you should be able to get this one. And it is C. Dementia is defined as the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. Alzheimer's disease is an example of dementia. In contrast to dementia, delirium is an acutely altered mental status, such as that can be caused by hypoglycemia, as one example. So we pretty much have gone over the incorrect answers, but just to go over them again quickly, the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function is called a senility. That's incorrect. Senility causes forgetfulness and confusion, and the person is mentally less acute later in life. B, delirium. Delirium, as we just mentioned, is acutely altered mental status brought on suddenly. C, dementia, that is the correct answer. And delusion is, we actually didn't talk about at all. And the definition of delusion is a fixed belief that is not shared by others and cannot be changed by a reasonable argument. You all know examples of delusion, I'm sure. 6. A 71-year-old man with a history of hypertension and vascular disease presents with tearing abdominal pain. His blood pressure is 80/60 milligrams of mercury. His heart rate is 120 beats per minute, and his respirations are 28 breaths per minute. Your assessment reveals that his abdomen is rigid and distended. Considering his medical history and vital signs, you should be most suspicious of A, an aortic aneurysm, B, a hemorrhagic stroke, C, an acute myocardial infarction, or D, an infarction of the large intestine. This one you should easily get because we covered it in another chapter. It is A, particularly because this gentleman has suffered from arteriosclerosis, which is a vascular disease. And it causes the arteries to thicken, harden, and calcify, and it places the patient at risk for stroke, heart disease, bowel infarction, and hypertension, among other conditions. Hypertension and vascular disease are significant risk factors for an aneurysm, which is a weakening in the wall of the artery. Now, the reason I say we went over it earlier is because this patient is making you suspicious of a AAA, an abdominal aortic aneurysm, and we went over that earlier with trauma and pelvic fractures. And so the MOI or NOI, nature of illness, may be different, but the symptoms present the same. And in this case, you are suspicious because of the fact that he has arteriosclerosis, which you know undermines the integrity of blood vessels, including the aorta. So we went over A, which is aortic aneurysm, or AAA. In this case, it is abdominal aortic aneurysm, AAA. B, hemorrhagic stroke. That's not correct because a hemorrhagic stroke is more likely to be seen when the patient complains of the worst headache of their life. They can lose the ability to speak and eventually become difficult to arouse them. They don't want to stay awake, and it can tend to worsen over time. C, acute myocardial infarction, and although the patient history could predispose him to acute MI, the symptoms that he presents are not that of an MI. They are of a AAA. And D, infarction of the large intestine. If they had an intestinal rupture, that causes a massive pouring of bacteria into the abdomen, and the peritoneum immediately becomes inflamed and very rigid, and you would have symptoms of peritonitis. In this case, you do not. You have an abdominal pulsing mass. So make sure, as I've said before, that you are clear about pathophysiology and what presents how, etc. Number 7, which of the following is a physiologic change that occurs during the process of aging? A, increased elasticity of the alveoli. B, a gradual decrease in blood pressure. C, a decline in kidney function. Or D, a 10 to 15% increase in brain weight. If you read this carefully, this one is quite easy. It is C. As a person gets older, certain anatomic and physiologic changes occur. The alveoli in the lungs becomes less elastic, not more elastic, which was your option for A, even though their overall size increases. Blood pressure gradually increases secondary to the process of arteriosclerosis, which is hardening of the arteries. Decline in kidney function occurs because of a decrease in the number of nephrons, which are the filtering cells inside the kidney itself. So by the age of 85 years, in terms of the brain, it's a 10 to 15% reduction in brain weight, which causes an increased risk of head trauma, which we discussed not too long ago. So we've discussed the incorrect and correct answers. Of course, alveoli lose their elasticity with age. Blood pressure increases with age, generally because of arteriosclerosis. C, decline in kidney function. Of course, that's the correct answer. And D, 10 to 15% increase in brain weight. The opposite is true. It decreases in weight by roughly the same percentage, or a little bit less than that, 5 to 10%. Number 8, which of the following conditions make the elderly patient prone to fractures from even minor trauma? A, hypertension. B, osteoporosis. C, arteriosclerosis. Or D, rheumatoid arthritis. Knowing diseases and medical conditions and their symptoms and what they do to the body itself, if you know those, this one is easy. It is B, osteoporosis, which is a decrease in bone density that causes bones to become brittle, and it makes elderly patients prone to fractures even from minor trauma. Some people have osteoporosis where their bones have become so thin that they can literally fracture a hip by getting up from a chair. That's something to bear in mind when you're treating someone with osteoporosis and you're padding backboards or filling void spaces when packaging them for transport, etc., and helping to assist them. And it is more common in postmenopausal women because of the sharp drop-off in estrogen. However, men have estrogen in their system too, and that drop in estrogen production can cause men to have osteoporosis as well. Now, I said knowing which disease or medical condition causes what would make this answer easy. And if you don't know what hypertension is by this chapter, then promise me you'll go look it up. But hypertension, of course, is high blood pressure. Osteoporosis, we just went over. Arteriosclerosis, we just talked about in the last question, is the stiffening or hardening of the arteries. And D, rheumatoid arthritis, is doesn't fit the bill at all. It's an inflammatory disorder that affects the whole body and leads to degeneration and deformation of the joints. Number 9, polypharmacy is a term used to describe a patient who takes A, multiple medications, B, other people's medications, C, one medication more than once a day, or D, medication only when he or she feels the need to. this one should be very easy as well. It is A. Polypharmacy is a term used to describe a patient who takes multiple medications every day. The more medications a patient takes, the greater risk of a negative drug interaction. So they might have high blood pressure and take a medication for that, along with type 2 diabetes and take 1 or 2 oral meds for that, along with perhaps neuropathy, and there are medications you can take for that. So anytime they take more or multiple drugs, there is an increased risk for interaction, especially if they try to take herbal supplements on top of that. And over-the-counter medications as well. So let's look at the incorrect answers. B, other people's medications. Of course, that's incorrect. Polypharmacy is not one medication more than once a day. There are a lot of medications taken more than once a day. And D is not correct because polypharmacy does not mean that they take it only when he or she feel the need to take it. When they take it only when they feel like they need to, that's considered non-compliance, not polypharmacy. Number 10, inflicted bruises are commonly found in all areas except A, the buttocks, B, the lower back, C, the inner thighs, or D, the forearms. If you think about what we were discussing late in this slide presentation, you should get this one. It is D. Inflicted bruises are typically found on the buttocks and lower back, genitalia and inner thighs, cheek or earlobe, upper lip and inside the mouth, and neck. Bruises to these areas should highly increase your index of suspicion for abuse. And we just discussed the areas where you're most likely to find inflicted bruises. Generally, D is incorrect because generally people are not, if they're abused, not beaten over the forearms. The fact that they're touched anywhere is awful, but you're not likely to see inflicted bruises there. Thank you for your time and attention for this specific topic, geriatrics. It is long and involved. The human body is very complex, and as we go through different phases from infant to child to adult to geriatric, there are a lot of changes physiologically, medically, etc. So there's an awful lot for you to review. Please also take the time to go over the tables and charts that were brought to your attention in this slide presentation. It's very important information. And again, we'll see you next chapter. And as always, once again, thank you for your time and attention.